for the telephone. It changed the world because it made communication much easier. Before the telephone was invented, people had to go personally to someone's house to tell them something. Imagine we still had to do that today. Alexander Bell made the first long-distance telephone call in 1892, reaching Chicago from New York. How important is communication for us in today's life? Why don't we communicate with our patients? Why are there prolonged waiting lists? Prolonged time to do workups? Prolonged time to be transplanted? I want to take you to a little bit of a journey, what's been happening in South Africa in the renal world. And I have come across the South Africa Renal Registry annual report of 2020, which was very remarkable. And I'm going to share share a little bit of information out of the registry with you tonight. In 2020, we were a population of 59 million people in South Africa. The population data by ethnic groups: African, 48 million, colored, 5.25 or 8%, white, 7.8%, and an Indian, 2.6%. If we break it up in the different provinces, we can look at Eastern Cape, it's 11%, Free State, 4.9%, and then we go and we see KwaZulu-Natal, 19%, Gauteng, 26%, which is the most populated, Limpopo, 9%, Mpumalanga, 7%, Northwest, almost 7%, Northern Cape, 2%, and Western Cape, 11.8%. Please be mindful, in each and every province, there are people who are in need of kidney therapy. Are we really serving our people? Treatment centers for dialysis and transplantation, the number of centers contributing data was 296 centers. Out of the 206, 80% of them were privately owned. Several provinces have increased access for their public sector patients by utilizing spare capacity at private hemodialysis centers on free per treatment basis. If we look at the numbers, in the Eastern Cape, public 4 centers, private 23, Free State 7, 14, and we can carry on and see where we actually tally them all together up to 296. It is evident that we don't have enough public sector slots in South Africa. Prevalence and incidence of renal replacement therapy, the total number of patients on therapy on the 31st of December was 8,734 people. This is a prevalence of 146 per million population. The province with the highest patient number remains in Gauteng, followed by the Western Cape and KwaZulu-Natal, whereas the province with the highest prevalence was the Western Cape, followed by the Free State. There were 672 patients who started on treatment in 2020, and an incidence of 11.3 per million population. Most of these patients, 73%, were treated in private centers. This is just a graph, just again to just display exactly what I've just read to you in the different provinces. And we can see there that in Western Cape, 268, Gauteng, 165, and then the least was in Mpumalanga of 51. Although I can also add on, in Mpumalanga at the moment, we are actually not servicing them correctly because we're not offering them the correct method of treatment by offering them a transplant at this stage. There's a few things that I've discovered in the last few years that we are really not serving the people the way we should serve them. Because if you are offering dialysis, which is only but a gap to transplant, you should have a transplant program. So are we really looking after our patients? The number of patients treated in the public sector declined with a prevalence of 44 per million population. The private sector, the prevalence was 729. That's a significant number. The numbers of patients and prevalence of by province and healthcare sector are shown in table 5 and figure 3. Denominators for prevalence calculations are based on the Stats South Africa midterm estimates. Medical aid beneficiaries who were unclassified with respect to province were allocated to provinces a proportion of the number of beneficiaries in each province. If we look at our population, per million population in the public sector was 50 and private was 8.9. Patients on treatment, 2,248, and comparing to private of 6,486. Again, if we look at the different sectors, there's quite a distinct discrepancy between the two sectors, which is a huge problem for our public sector patients, which are not then adequately receiving treatment. And those are because of numerous reasons. Then we also have our different treatment modalities. As we know, as with kidney failure, we need dialysis. Either we're going to get hemodialysis or PD, and also transplant is the end result. What's very interesting is that hemodialysis in the state sector is far less than in the private sector, where your PD patients are again predominantly treated with peritoneal dialysis than your hemodialysis in the public sector. Keeping in mind that our public sector do not have enough slots currently to serve all the patients. If you look at this graph, you can see that the hemodialysis for public sector patients versus the private sector patients, and then again your PD patients versus your public and private sectors, and then your transplant numbers. This is a graph that was displayed last week by a conference, and I need to give all the credit to Professor Gottlieb and Professor Minion for allowing me to use the slide. Thank you very much. Currently, statistics in South Africa is very alarming towards, if we look at what's happening with our children in South Africa. Currently, these statistics are from January up until 31st of August, 2023. There are currently 140 children countrywide on chronic dialysis, whereby only one pediatric transplant was done with a cadaveric donor, deceased donor. And then we had 7 living donors. And the unfortunate thing currently what's happening is kidney transplants has only been happening so far this year at Red Cross Hospital and in Pretoria Private Hospital, in Gauteng and in the Western Cape. Not that the other hospitals don't offer, but it's just unfortunately we haven't been transplanting. In March 2020, the Gauteng Province Solid Organ Transplant Division started a new allocation program, and we've also started to transplant pediatric patients at Nelson Mandela Hospital. And I'm very proud to say that we've already transplanted 6 patients, 6 pediatric patients at Nelson. Unfortunately, this year we have not transplanted any child for various reasons, and mostly of them are because they are not a match. When we do have a cadaveric donor, unfortunately, they do come up as a positive match, cross match with the donor. We also do work up our living donors, but unfortunately, we also have a pool of donors that we are struggling to actually get fit donors, because most of our living donors in the public sector, what we've noticed, also has chronic diseases, and therefore they can't always be then signed off as being fit as a living donor. Pediatric kidney transplantation has essentially stopped in the public sector outside of Red Cross. It's a very strong statement. I won't say it's stopped, but definitely it's on hold at the moment due to the fact that we do not have enough donors. So are we really serving our kids? Are we really serving our population? What is renal transplant in South Africa? I'm a firm believer that dialysis is only but a bridge to normality. What do I mean by that? When a patient are diagnosed with kidney failure, their whole world are shattered. Everything has been taken away from them. They lose their jobs, they lose their families, they lose their loved ones, they become very lonely, and they become very ashamed because it's almost like a stigma that hangs over their heads. I had the opportunity on Saturday to attend an awareness in Mafeking. One of the renal patients who does this on an annual basis, she gets the community together with patients, doctors, nurses, dialysis units, and do an awareness. It was a very, very successful awareness. But what stood out for me in the awareness was two particular patients who are waiting for a kidney transplant. And although I've been now in transplant for more than a decade, and I've heard many testimonies, and I've sat in many, many meetings, and I've listened to many stories. The one particular person who spoke, really, his words hit me very hard and deep. And he said that we are grateful for our doctors. We are grateful for our nurses. We are grateful for everything that you do for us, but we are not supported. Three of his colleagues, as he calls them, who was dialyzing with him, actually was so severely depressed that they just gave up, got overloaded, and we all know what happens after that. They actually died. He's heartbroken. Himself are depressed. And he said, and the man I'm talking about was a person who was actually a very influential person in a very high position in a sector where he worked. And when he became sick in 2018, he lost everything. He lost his job, he lost his wife, he lost his whole life. He's now been waiting ever since for kidney transplant, which is not happening because we have dismal amount of donors in South Africa. But what really, really stood out for me was this man's, the way he distinctly described the loneliness that you go through when you're on dialysis. At Charlotte, we've got a school, and we have many children who's on dialysis, and they go to school after dialysis. They go to Nelson Mandela Hospital. They come from Nelson, they go to school, or vice versa, whichever way it is. And one day I had actually a discussion with one of the little ones. It was the end exams, and I said to her, "What are you busy doing?" Because she was sitting with her books on the lap while she was on dialysis. And she said to me, "I'm busy studying, sister, because we are writing our final exams." And that little girl actually, after dialysis, 4 hours on the machine, went and she wrote her end-year exam. She became instantly one of the most amazing people I've ever met, because I know and I've heard that people are very, very exhausted after dialysis. And here, this little girl is so brave. She sits on dialysis, and after that, she actually goes and she writes her exam. But what life is that really for a child? Because all she knows is her hospital. She only knows the doctors and the nurses. We are her family. We are her friends. We are her everything. Looking at the suicidal rates going up in South Africa and around the world is even worse among our teenagers, even worse among our patients who's got renal failure, and even worse with our teens who's got renal failure. So therefore, dialysis is only but a bridge to transplant, who gives the gift of life and who gives life back to people. Give people back to society. Give people back that they can go back and have a job. They can go get back with their loved ones. They can feel whole again. They can look at themselves in the mirror and be proud again of who they are. Because dialysis destroys not only your kidney, but it destroys every cell of your being. Who governs transplant? The National Health Act, 2003, Chapter 8, Anatomical Donation of Post-Mortem Examinations, Department of Health, good guidelines on transplantation, good clinical practice is the ethical obligation, and then we should not ever forget the Declaration of Istanbul on organ trafficking and transplantation and transplant tourism. Just a little bit more about the Declaration of Istanbul. Organ transplantation, one of the greatest medical success stories of the 20th century, has prolonged and improved the lives of hundreds of thousands of patients worldwide. Countless acts of generosity by organ donors and their families, as well as the many important scientific and clinical advanced achievements by dedicated health professionals, have made transplantation not only a life-saving therapy, but a symbol of human solidarity. Yet, these accomplishments have been tarnished by numerous instances of organ trafficking, of trafficking in person for the purpose of organ removal, and of patients who travel abroad to pursue organs from poor and vulnerable people. And in 2007, it was estimated that up to 10% of transplant worldwide involved such practices. To address the urgent and growing problem posed by these unethical activities, the Transplantation Society and the International Society convened a summit meeting in Istanbul in April 2008. 151 participants, representative of scientific and medical bodies, government officials, social science and ethicists, reached consensus on the Declaration of Istanbul, which has been subsequently endorsed by more than 135 national and international medical societies and governmental bodies involved in organ transplantation. The Declaration of Istanbul expressed the determination of the nation and transplant professionals and their colleagues in related fields that the benefits of transplantation be maximized and shared equitably with those in need, without reliance on unethical and exploitative practices that have harmed poor and powerless persons around the world. It aims to provide ethical guidance for professionals and policymakers who share this goal. And I must be saying, we are very proud in South Africa that is something we are practicing. We are ethically doing the right thing all the time by means of organ donation and transplantation. We will not tolerate any organ trafficking, although all coordinators and maybe some of the doctors have been, at some time in their career, been exposed to somebody who will make an unethical approach to them regarding an organ, asking them, can I sell my organ? We see that on a regular basis, where people will actually come to my office or they will call me and say, I want to sell my kidney. How much will you pay me for my kidney? And then we need to go back to them and say, in South Africa, it's unlawful and we do not buy and sell organs. And we need to explain to them why. So therefore, in South Africa, we stand by, it's a gift of life, and it's a gift from the community members to other community members, and we cannot be selling organs in South Africa. Just a little bit more of our centers in South Africa. We've got quite a lot of centers in the different provinces. Gauteng, we've got Charlotte, who does kidney transplants. We've got Dr. George Makare, who used to transplant. At the moment, it's on hold, but they will restart the program this soon. Jacaranda Hospital, Mill Park, Sunning Hill's got hearts. Let me just go through the kidneys. Nelson Mandela's doing kidneys for us. So currently what we're doing, all our state sector patients in Gauteng gets transplanted at Nelson Mandela Hospital. Steve Biko does kidney transplants. Fitzonald Gordon does kidney transplant. Then we get KwaZulu-Natal. We've got Itugeni Hospital in Nkosi, Life, Netcare St. Augustine's, Chris Skier in Western Cape, Chris Barnard. We've got UCT, we've got Red Cross, Tygerberg, and also in the Free State, we've got Universitas and private and academic hospital. They have not been practicing for a while, but we are all helping each other to get all these centers back and running up again. So mentioning all of these, there's quite a lot of centers in South Africa. Therefore, again, are we servicing our patients correctly? Are we doing the right thing? Are we filling the gap? Because we cannot say we don't have transplant centers. We have enough transplant centers to actually serve the population of South Africa. A little bit of stats of the last decade. If you just look at the kidney portion on this side here, 2,416 kidney patients was transplanted. Pediatrics, 8 in 2009, 18, 2018, 23 in 27, then 15 again, 2016, 20, 2015, and 244 in 2010. And unfortunately, as the years go up from 2010, the numbers of transplants starts decreasing. The more transplant, the less we transplanting, the more patients are dying on the waiting list. This was a review I've done for 5 years, from 2017 to 2021. I just want to go through the statistics here a little bit with you. So the national deceased organ donation rate per million population, you can see it came from 1.6 all the way down to 0.48, which is really, really catastrophic, because it means lesser and lesser people are actually donating organs. Looking at the red graph, you can see the population has grown. At the end of 2021, we were more than 60 million people in South Africa, with a dismal 0.48 per million population donor rate. Then if you look at the purple graph, we're looking at the deceased in the private and public sector. These are numbers that was consented cadaveric donors who actually went to theatre. Remember, sometimes we can have a donor consented, but something happens and we can't utilize the organs, or sometimes, unfortunately, the donor has a cardiac arrest and we can't utilize the organs. Again, dismal numbers. As you see, there was a constant in the 90s, 2007, 2008. From 2019, it sloped down to 68. In 2021, a very, very low number of 38 consented national donors who actually went to theatre and actually donated their organs. Then if we're looking at the transplant activities, I'm going to concentrate more on the renal side tonight. In 2021, there was 2,382 patients on the active waiting list, and the mortality rate nationally was 162. Then more statistics on renals. From 2017, your deceased donor renal rates, private and public sector, again, just the discrepancy to show you from the cadaverics. 2017, 129. Then we had a bit of a better year in 2019. 2020 was only 60, while expected, because we're in the midst of COVID. And then living related was stagnating around 83s, 76. That was the norm. We dropped way down in 2020, also due to COVID. Remember, there was a time where renal oral Ds was seen as an elective surgery, so we were not allowed to do it. And then again, it bumped up in 2021 to 57. And I know in 2022, it looks a bit better. So these are the statistics. Let me see if I can move this. Those is my slide there, sorry. The statistics for 2022. So we are 20 centers. The number of chronic renal failure patients on dialysis at your center during the previous calendar year. These are all the centers I mentioned, these 20 centers, for 4,149. Then patients added to the waiting list during that period of 2022 was 1,342. The number of patients on the active list, estimating of the calendar year, was 1,689. And unfortunately, 262 patients demised on the list as well. Then what did we do in transplant? Please be mindful, these are national numbers. Kidney transplant total from a deceased for adults was 81, pediatrics was 7, and then patients from your DCD, which is your donation after cardiac death, with 3 for adults. Pediatrics was 11 living donors. Adults was 129, and then we did not have any altruistic donors, and we also did not do any pair exchange. I'm mentioning those last 2 options just so that everybody is aware that we do have many more options of kidney transplantations that we can do. We've put so many programs together to see how we can actually increase the donor pool and how we can actually increase the transplant pool so that we have lesser patients waiting on the waiting list. So normally this is a question that happens quite often. Let's ask, where are the donors? So what does the transplant coordinators do? We do quite a bit. We've done awarenesses in March when it was Renal Day. We've just done quite a bit now of Renal Week. We do CPD training, we train link nurses, we train dialysis nurses, we do a lot of monthly awarenesses. August awareness drive was amazing. We were on different radio stations, TV channels, we do hospital visits, community outreaches, we do living related and non-living related workshops. We give ongoing support to our patients, and then we do the renal workups. So from our side, from the coordinator side, there's always room for improvement. But it's very important that everybody understand we do a lot of awareness. We do a lot of training from our side, and we are less than 70 coordinators in the country. So doctors still ask, where are the donors? Unfortunately, doctors, I wish there was a stalk that could bring them to us, but we don't have that. We are relying on our doctors as well. Lack of identifying referring potential organ donors is one of the biggest conundrums currently in South Africa. We as coordinators are struggling. We are not as many as the doctors on the floor. We cannot do this alone. My plea tonight to each and everyone on this platform is to please, if you are involved in any means of any place in a hospital where you can identify a potential organ donor, please do refer the patient to us. And that's what I mean is either a person with a poor prognosis, or otherwise a person that is brain dead. Then we also have a lack of interaction of transplant coordinators on awareness days. Awareness days are not only for procurement, it's not only for coordinators to do that. We need to start taking hands of allied doctors and nurses. Everybody needs to do this together because we cannot do this alone. If we all do awarenesses together, then things will get better. If we have doctors that talk the same language as the nurses and the coordinators, we can really make a very, very big difference. Lack of discussing transplant options with renal patients. Again, if I refer back to my meeting that I had the weekend, the very same person who said they get a lack of support actually made mention the day when he was diagnosed with kidney failure. And he's a paramedic by profession. So he's got medical background. He actually was just told, you've got kidney failure and you're going on dialysis. That was the end of the story. That was the end of discussion from the doctor's side. There was no explanation. There was no what happened, what's the next step, nothing like that. And please, I'm not picking on doctors. I'm pleading to doctors tonight. Please help us. We need your assistance. We need your help to make a difference. We cannot do this alone any longer. We've tried and we will keep on trying and we will do what we can, but we need your support. We need you to be out there. We need you also to be the ambassadors for renal patients, to talk about dialysis. That's only but a bridge, and transplantation is actually the cure. Many patients, when they go into dialysis, they will sit there for many years. for two reasons. Either they don't know about transplant because no doctor's ever told them that there's something like transplant. And I've got evidence. Many patients have told me before, private and public sector, just I didn't know there's something like transplant. Nobody ever told me that I can have a transplant. Or the other side is that they are not fit enough for transplant. But from our side, we need to do everything in our possibility that we can to please talk to patients about transplant. They cannot get comfortable on a machine. They cannot be confined to a machine 3 times a week for 4 hours and make peace with that is their destiny, because it's not. Once a patient is transplanted, we open another slot for another patient. That is how it works in the state sector. We do not have enough slots. We do not have enough resources. We are pleading the doctors to please out there help us identify more donors. Even with living donations, please speak to your patients, nephrologists. Please speak to your patients who are on dialysis or even if they're just preemptive. Please speak to them. Let us get them transplanted. They don't need to be on dialysis year in and year out. There is life after transplant. Please, let us be their voice and let us not become comfortable seeing them on dialysis every day. Let us bother us. Let it stir something in you that's not right. This person should not be on machine forever. Of course, there's some of the patients that you cannot take off. Of course, there's some of your patients that cannot be transplanted. But surely the majority, we can work up, get a donor, and get them back into society. So the question remains, are we failing our renal patients? Transplanters, renal nurses, doctors, are we failing our renal patients? Mr. Kupedi Mochiatsi is a very dear man to my heart. I met him a year and a half ago. He was a professional soccer player. He got sick and he thought he had flu. Went to the doctor and he was diagnosed with end-stage renal failure. He was on dialysis for 6 years. He never gave up. He was committed to get transplanted. He was committed to get back to life. In the interim, he lost obviously all his friends. He lost his career as a soccer player. The only person at the end who stood by him was his dear mom that you can see in the picture. He became an ambassador for transplant. He became an ambassador to save lives. He was probably one of the most profound people I've ever met. The most passionate person. When I called him to say we had an awareness, he was there. He used to preach the word of organ donation and transplantation better than any of our coordinators could ever do that. He got a transplant. Unfortunately, in 10 months' time, he went in rejection for whatever reason. He had to go back on dialysis. It crushed him. That young man I met the day when I called him up for transplant, he was ecstatic. He was so excited. He was so overwhelmed with joy and happiness, and that he's going to get the gift of life. He's going to get a second chance. And that's exactly what he got. He recovered quickly. He had big plans. He had a future. He planned his future. He planned to go big and to go bigger and better, and just go and tell everybody about organ donation, how it saved him, and he did that. But his time was cut short. The article in front of you was written in July, and literally a day after this interview, he passed on. He got overloaded, and unfortunately passed on. And this was a young man who lived life to the fullest. It was a young man who really embraced organ donation. He was so grateful to his donor's family. He wrote the most beautiful letter. His mom was crushed, but she was so grateful that organ donation gave her son back for 10 months. 10 months is a short time, but for them, it was a lifetime together again. We will remember him forever, and the other ones who has fallen. But please, my plea to you tonight, doctors, allied workers, nurses, managers, professionals, healthcare workers, let's stand together and do something, because we can. We used to call him Chili Boy. That was his nickname, Chili Boy. And he was really ambassador for transplantation. He was proud of his kidney. His kidney's name was Mpo. That was his nickname. And he really just loved his new kidney. He loved his new life. He loved everything about transplant. He went back to dialysis units to actually encourage patients to be compliant, to listen to the doctors, to listen to the nurses. He was really, really ambassador to preach the word of organ donation and transplantation. And he's definitely been taken too early. So I would like to ask again, does it really matter who invented the light bulb? Or do we just want the lights on? Does it really matter who invented the telephone? Or do we just want a workable network and communicate without breaking in the signal? Does it really matter who is at fault? With dismal transplant numbers, overflowing dialysis units, patients not being listed, patients dying on the waiting list? Or can we together stand tonight together and start making a difference? One patient at a time can rebuild, and we can rebuild the bridge. We can fix the bridge. We can give them back hope. We can give them back life. And most of all, this is one thing many patients said to me again weekend, that peeing is a wonderful thing. Can we give them that? Can we, as healthcare professionals, give them back that wonderful thing? Because I do believe together we can. In isolation, we can't get it done. But together, we can definitely make a difference. I would just like to acknowledge the scientific report or guidelines, the 5-year national organ transplant activity of South Africa, the RED education file, and also then just the Declaration of Istanbul for some of the resources I've used to compile this presentation tonight. Thank you very much.
Wow, thank you very much. What a passionate presentation and a plea at the end, Ms. Meyer. And indeed, as you said earlier on, that we tend to think that renal dialysis is the end of managing patients with chronic renal failure. But I think tonight it is quite clear that we need to have think about beyond renal dialysis, hemodialysis, or HD. And colleagues, we've heard this message and want us to engage on this discussion that has been made. My question to you, Ms. Meyer, because you're saying that I see the pictures you indicate that there are more patients on renal dialysis in the private sector than those they are more in the private sector than in the public sector. And what you're also saying that if a patient gets a renal transplantation, you're opening up a slot for another patient who can come on to renal dialysis. This message seems to be lost amongst the clinicians, or maybe I'm overstating it or misrepresenting them. is that the impression that perhaps that there's a tendency to keep patients forever on the hemodialysis rather than think of the possibilities of a renal transplantation?
Thank you, Dr. Bula. Yes, it is very, very true. We do have more patients in private sector because they just have more slots. In the public sector, we are very, very limited with slots. And therefore, we are really, really preaching the fact that transplant is the way to go. Because every time a patient gets transplanted, number one, that patient gets off dialysis and actually gets restored back to health and back to life. And that should be the ultimate goal of any patient on dialysis. And then secondly, you're actually opening a slot for a patient who's been on a waiting list for dialysis. Because in the state sector, it's not like in the private sector where you can just go onto dialysis. We have a waiting list. That you're actually going onto a waiting list to get dialysis. And then you go onto another list again to get a transplant. So it's a very, very strenuous journey that the patients are on. And therefore, we cannot stop talking about transplantation. Because without transplantation, your patients will remain on dialysis for the rest of their lives. And as we know, the mortality rate also goes up. The longer you're on dialysis, the sicker you get, the weaker you get. And then you get up to a point where you're not transplantable any longer. So we need to be mindful of the fact that when your patients are on dialysis, please do your assessments and see which patients actually does qualify for transplant. Do we have enough transplant centers in our country to accommodate our patients who are on dialysis in public sector as well as in private sector? We've got different centers in different regions, different provinces. We've got surgeons. We can do this. We can bring change. But we also need the organs. And therefore, we can never just talk about transplant without organ donation. The first heart transplant would never, ever would have happened if there wasn't a donor. And that is exactly the same with any other person who needs a organ, doesn't matter what organ it is. We need a donor. We need a selfless act of kindness to actually bring forth to say, I would like to help. And this is the way I can actually leave a legacy behind my death.
Yeah. And I think it's also interesting that maybe it's illuminating, maybe I could put it that way, that there are more cadaveric donors than living donors. And what you're saying is that you're making a plea, especially for those people like us who could be donors. That's the message I'm conveying this evening.
Absolutely, absolutely. That is my plea. My plea is to please talk about organ donation. Talk about organ donation in your families, in your churches, in your communities, wherever you go, in your circles. Talk about organ donation. Because also the reality is, if organ failure has not knocked on your door, you don't think about it. That's an unfortunate thing. And we hear it time and again that, sure, I never thought of organ donation up until my father needed a kidney, or up until my child needed a liver, or up until my son went into heart failure. Those are not the type of talks we have around the table. Those are not the type of talks we have in our communities. And these are the things that needs to get out there. We need to start talking more and more about organ donation and transplantation. If I can just go back a couple of decades ago when HIV, and I'm a firm believer of what I'm going to say now, a couple of decades ago when HIV and AIDS was just discovered, it was a taboo. Nobody was allowed to talk about it, and it was a stigma, and it was just something you don't talk about it, and you know that was it, and that's almost the same category that transplantation and organ donation is in at the moment. But then decades later, it is just as normal as high blood pressure. We see it as a chronic disease. It's treatable. It's a household name. People talk about it. There's no more stigma to it. Or if there is, it's very little, very few. That is where we need to get organ donation and transplantation. We need to get it on that same platform where we cannot be shy to talk about it. We cannot stop talking about it because our patients are dying, our children are dying, our youth are dying, our mothers and fathers and brothers and sisters are dying. And organ donation, as healthcare workers know, knocks on any door. It doesn't matter who you are. It doesn't matter where you come from. Kidney failure will knock on any door. We know of kids who are very, very young. I mean, I'm talking about baby youngsters, 9-year-old, 10-year-olds who need kidney transplants. We've got many, many pediatric nephrologists online. They know, they fight for their babies, they fight for their children. We've got adolescents. We've got teenagers. They are our future. They are our next generation. How are we going to get them to health if we, as a nation, don't step in and say we are going to save our generations to come? We have to talk about organ donation. We have to talk to our renal patients about transplantation because they are getting too comfortable on the dialysis machine, and that's our fault. We are making that mistake to make them comfortable on a dialysis machine.
Yeah, talk about transplantation. The first question from one of the colleagues, Moses Abimana, wants to know, why are we not transplanting patients in Mpumalanga through other provinces?
It's not because we're not transplanting, it's just because there's not an existing program. If I can make an example, there was no existing program in Mafeking. And then 3 years ago, we actually, from the Gauteng Province Solid Organ Transplant Division, we actually then started to have a partnership or collaboration with Mafeking. We've identified, and that's also what we have been doing. We're identifying regions where there are dialysis units, but there are no transplants offered. So 3 years ago, we've actually discovered Mafeking's got a transplant unit, and they are not, nobody's actually assisting them with transplantation. We then took them on board. So currently they are listing with us in Johannesburg. We've already listed 2 of their patients. They are doing a great job there, and they are working our patients also much quicker with more assistance. Mpumalanga don't have, that is our next step, is to actually go to Mpumalanga October, November. We have started to make means of some of the doctors on that side to start building relationships, and then also then to see how we can actually help them on their side and how can we get the patients listed and transplanted. So we are identifying all these different regions that just hasn't been, how can I say, they just haven't been on the radar for transplantation. I think nobody has really took the time to embark on that journey with them. And also, again, many of the nephrologists, Dr. Bila, in these small towns are not aware of transplantation. They're not aware that we can actually offer their patients transplantation. So another plea to me tonight with all the doctors online, please, if you know that your unit is not, how can I say, linked to a transplant center, please call us. Let us link you to your nearest transplant center and offer your patients the best possible option of care.
Thank you very much. So what you're saying, that every renal dialysis unit should have a link with a transplant center?
Absolutely, absolutely. We have enough centers to link people up to the different centers in the country.
Yeah. Moses comes back again. How do we support our renal patients with psychosocial services in the private sector, considering the limited benefits with social workers?
So that is a bit of a problem. we do is, example, I'm going to go back to Mafeking because that's our latest baby, if I can call it like that. With very, very limited resources. In public sector, I think we can all agree that the resources are limited. But what I also have learned in the last few years being in the public sector is there are means and ways to do things, and we help each other and we stand together. So what we've done is our social worker in Mafeking did not know how to do assessments on renal patients. And then what we did from my side is I've actually made an arrangement with our social worker to connect with her, and she taught her how to do then the assessments. So I know hospitals are limited on social workers. Many hospitals only have one. So, and also they can't be flooded with transplant patients. And therefore you need to then start on a small scale. Like for instance, let's take Mpumalanga. Let's say we start a transplant program from their side, they connect with us and we start helping them. First of all, we need to see if we can then actually employ a renal transplant coordinator in that hospital or in that facility, because one thing is for sure, you cannot run a transplant facility or unit without a transplant coordinator, because the coordinator will be literally coordinating everything from where you identify the patient up until where the patient are listed for a renal transplant. Then we can start doing training with our social workers. And I'm proud to say in Gauteng, we are really for training. We train whoever needs training to set up the units. We help them and we assist them up until where they're comfortable in doing it. And also, you need to be able to list your patients with a center. Like Mpumalanga will either have to list with like Steve Biko or come to Johannesburg, but Steve Biko is more closer to Mpumalanga, so that will be the route. So we need to then link you up with a transplant center where the transplant can happen, where workup can be happening, where listing can be happening, and then transplant and the aftercare.
Yeah.
But with the social workers, we can teach them how to actually do the assessments.
Yeah.
If that answers the question, Dr. Moses.
Okay. Yeah, let me just conclude this discussion on transplant and dialysis. There's someone, Nazima Keda, says that the problem with why perhaps medical professionals, suppose nephrologists, do not want to work to prepare or work up patients for renal transplantation is because they want to make more money. It's an ethical question. I wonder if that is the case in terms of revenue versus patient care, ultimately.
Dr. Bella, I think that is something that each and every nephrologist will have to answer for themselves. I think that's an internal question that nephrologist will know. Is that true or is it not true?
Yeah.
Again, you need to refer. The ethical, correct thing to do is, if you are a nephrologist, if you are looking after renal patients, if your patients are fit for transplant, it's an ethical obligation to refer them to a center, do their workup, and get them transplanted. That is the correct ethical method and the correct thing in medicine.
Yeah, next question. I'll go back to Moses because he's got lots of questions, but before I go back to him, Stella Maloga wants to know what are the qualifying criteria for being a kidney donor or a recipient? How do I know that I qualify to be a donor or a recipient?
So to be a living donor, you need to be above the age of 18. Again, center dependent. Some centers says you must be older than 25, other centers says 18. The best will be is that you need to contact one of your centers, the center that you would like to work with, and then that center will actually send you all the guidelines or the resolutions from their side, because centers do differ. Like what you've seen, we've got 20 different centers. although we all do the same principle, we do have different criteria in South Africa. So the best will be is to identify the center that you would like to work with, and then that center will actually educate you on how to work up your patient, donor and recipient, and also what are the different criteria for the patient to be met to be able to qualify for a transplant.
Yeah. And then still back to Moses, how does one get hold of the transplant coordinators for training in the private sector? And the question related to that, how do we improve the transplant workups, considering that we now have 3 transplant centers in Charlotte Maxeke, the Johannesburg Academic Hospital, Mill Park, and Donald Gordon?
So if you are looking at, if it's a, let's talk about a public sector patient. If it's a public sector patient, you will refer the patient to myself, and then we'll take the process from there, or I can explain the process from there. If you are looking at the private sector, it is the nephrologist's prerogative to make a decision. Would you like to refer his patient to Mill Park or to Donald Gordon?
Okay. And how to improve the services between the 3 centers in Johannesburg?
To improve the services.
Yeah, how to improve the transplant workups. There are 3 centers, Charlotte, Maxeke, Mill Park, Donald Gordon.
So in Johannesburg, we work very similar. The workups work very similar again. The workups will be done by the coordinators in the different centers, either Charlotte or Mill Park or at Donald Gordon. You have to, I'm not sure if I'm answering your question correctly, Dr. Moses. You have to choose your center that you would like to send your patients to. The coordinate from the nephrologist to nephrologist, there's a referral process, and then the coordinator will start the workup and share the whole workup with you as a doctor to say, these are the investigations that needs to be done. And then from there on, you and your coordinator will work hand in hand to get the patient worked up. And then once the patient is fully worked up and ready, there's a panel. Donald Gordon has their own panel that they run monthly. And then Netcare and the state sector has a panel combined, which runs once a month. And then the patient gets listed, presented via the panel, listed, and then go on to the different lists. In Gauteng, we've got 3 lists. We've got a state sector list, you have a Mill Park list or a Netcare list, and you've got a Donald Gordon list.
Okay. No, thank you very much. Thanks for that. Yeah, I hope the question has been answered. There's a comment by one of the people who are, I think she's a nurse, Daphne Tlabela, who says, we're discussing kidney transplant to renal dialysis today, but she's got someone, a very close relative who had liver transplantation and sadly died. That's one of the other problems, that with the transplantation, there's also rejection. What is the data that shows how many patients who go on to be on renal transplantation or liver transplant survival rate? Do we have data for that?
Yeah, we do. Unfortunately, that is one of the sad things about transplantation. It is, we always say there is always the other side of the coin is, unfortunately, rejection is there. When transplant work, it is magical, but unfortunately, there are some patients who reject for whatever reason. They're looking at the survival rate maybe from 2 years, 5 years, 10 years onwards. Depends on the patient's condition prior transplantation, depends on the prior etiology, and also very, very important, depends on the patient's compliance. And that is why even on dialysis, a patient has to be compliant. And that is where and even with the workup of a liver patient, when we start working up patients, we look at their compliance. Are they coming to their appointment? Do they adhere to their appointments? Do they adhere to the medication that they're on, etc.? Data evaluation already starts from the day one to see if they are compliant. If we look at a dialysis patient, Is the patient now and again, say on a Monday morning, overloaded? Are they following the right diet? Are they drinking their tablets? All those type of things lead to compliance. If there is no compliance pre-transplant, guaranteed there will not be compliance post-transplantation. And unfortunately, some patients do reject because they are not compliant. But the patients who follow the rules, obviously, you can still reject for various reasons, but the outcomes are much, much better. We do have a very good survival rate. And again, to get a transplant is still a better option than to not get the transplant at all, especially with a liver transplant patient. Their times are limited. I also work with liver transplant workups. They do not have a bridge as per renal like dialysis. A liver transplant patient, the liver, when they go into liver failure, it can be a matter of months or days, depending if it's an acute or a chronic. If it's an acute, they literally have hours to live. If it's a chronic, they maybe have months to a year or two to live. So that's an urgent transplant that needs to happen.
Yeah.
And unfortunately, it's also a very, very high risk operation. So death can occur because it is a very, very complex operation. And again, then, post-transplant care, the recovery process. I always say, it is like any operation. Things can happen. You can bleed, you can get infection. And unfortunately, with transplant, there is that cruel word like rejection.
Yeah. No, thank you very much. We've run out of time, but it has been quite an engaging session. And I just want to thank you very much for this presentation and discussion that you presented. And I think that two takeaway messages. One is that patients on renal dialysis should not end up only with renal dialysis. They also need to, those who qualify, who are ready, who can be worked up, they should be moved on to transplantation, because doing that you might improve quality of life, but also you will improve quality of life, but also that you're creating a slot for another patient who's on the waiting list. Because I've seen that there's quite a lot on the waiting list, mainly in the public sector. And second is that there is a need for living donors, and that people here, each and every one of the people who are locked in today, friends, colleagues, families, they're possible living donors. So if we can just say from this discussion this evening that we'll become advocates for sourcing living donors for many patients who are out there seeking to get transplantation. So I just want to thank you for conveying this message, and I hope that I've captured it very well.
Thank you very, very much, Dr. Bill. I really appreciate it.
Yeah, and I also want to thank all the colleagues who've joined us, quite a number. We're quite grateful, and do not take this lightly that you are joining us every week to listen to various speakers from different fields, experiences, who have been walked this path in terms of wherever they've been, in terms of their qualifications, experiences, research, and up-to-date information. We just want to thank you for supporting Clinics Health Group by looking in every week to these webinars. And lastly, to thank, not second but last, to thank Clinics Health Group for allowing us to use this platform to be of service to all healthcare professionals within our communities, and also to thank the marketing division working together with me to set up these webinars every week. Kamo always there supporting this program. We just want to thank you and the team in marketing, and just want to say to all of you who have logged in this evening, may you have a good night and God bless you. Thank you.
Thank you very much, Dr. Bilang. Have a lovely evening, and thank you for the opportunity.
Okay, thank you very much. Have a good evening.